A 2-year-old executive has cardiometabolic risk, changing body composition, knee pain limiting training, and sleep concerns. And the unsafe response is to ask one giant chat, to review everything and trust whichever detail it happened to remember last, especially when the answer conceals which records informed each conclusion, and which questions received no focused review for the patient. You will learn 3 practical ideas. First, a subagent is a fresh, independent agent conversation assigned one self-contained clinical question. Second, delegation lets an orchestrator collect several structured briefs in parallel, without mixing their intermediate noise into one context window. Third, the physician reviews both the synthesis and the underlying briefs, much like an accountable clinician reviewing a multidisciplinary discussion rather than accepting a black box consensus. Delegation is the act of assigning a bounded task to a child agent, often called a subagent. In Hermes, that child receives its own conversation, its own allowed tools, its own budget, and only the context the parent intentionally passes to it. It does not inherit the parent's entire chat history, which is the key safety property. Use a medical analogy. A generalist does not call 4 consultants by saying, "You know the whole case, right?" Each consult contains the clinical question, the relevant records, the time frame, and what a useful answer should look like. A subagent is similar. Its goal must be complete enough to stand alone. If the task says assess risk, the agent has no reliable definition of the risk, patient scope, clinical evidence standard, or specific deliverable. A context window is the limited working space in which an AI model sees instructions. All conversation, source extracts, and tool results. One massive clinical chat becomes fragile because every note, lab panel, image description, and tentative conclusion competes for that same space. Summaries compress detail. Tool calls add volume. Salient but irrelevant text can crowd out the specific finding that changes the plan. Subagents create several smaller working spaces for focused review. A cardiometabolic reviewer can receive only the cardiometabolic data and a question about risk trajectory. A body composition reviewer can receive serial DEXA, training history, nutrition and medication context. An orthobiologic readiness reviewer can receive the orthopedic history, imaging reports, functional limitation, and the current regulatory and evidence constraints defined by the practice. A cognitive longevity reviewer can receive sleep, mood, cognitive concerns, medication contributors, and the permitted validated assessments. Each returns a structured brief, not an endless transcript. This resembles a mixture of experts model. It is 4 narrowly prompted analytic passes, each limited to an assigned evidence domain supporting one accountable physician. The value comes from decomposition and traceability, not simulated authority. Each subagent receives least privileged tools. For this episode, it can read the specific authorized patient source bundle and consult an approved evidence corpus. It cannot write to the EMR, message the patient, prescribe, or change shared memory. No leaf subagent can ever spawn more subagents. The result is not merely faster, it is completely inspectable. The physician can see which domain reviewed which inputs, what it found, what it did not find, which sources support the statement, and where the model expressed uncertainty. That is much more useful than a single polished paragraph whose internal path cannot be reconstructed. Consider a scheduled executive health 15 dimensions clinical review. The patient is not a hypothetical data container. They are a person with multiple potentially interacting concerns. And a broad AI prompt can manufacture coherence where the underlying record contains uncertainty. We therefore start by defining the task before any agent reads a chart. The physician or trained clinical operator creates a Kanban card, Executive Health Review Previsit Synthesis. The card includes the appointment date, responsible physician, review deadline, the approved dimension checklist, and a patient reference that resolves only inside the clinical boundary. It starts in previsit requested, The card is workflow state, not a duplicate record. The orchestrator first verifies the permission model. It uses a dedicated service account that can read only the named patient's FHIR canonical data objects required for previsit work. It cannot see unrelated patients, cannot write to the EMR, and cannot send messages. The system records the user, service account, purpose of use, retrieval timestamp, and source version. If the data platform cannot return provenance or the record is incomplete, it marks the card's source verification required and immediately stops. Next, the orchestrator retrieves a normalized source packet. This is not the entire chart. It contains the signed last assessment, active problem list, medication list, relevant lab trends with collection dates, imaging reports, prior DEXA or body composition data, documented functional goals, and the defined 15-dimension intake. The source packet is encrypted and scoped to the run, never copied to persistent memory. Then it creates 4 self-contained delegation clinical packets. The cardiometabolic subagent receives a question such as using only the attached longitudinal blood pressure, glycemic, lipid, ApoB, and LPA medication, family history, and relevant imaging data. Identify trends, gaps, contradictions, and questions for physician review. Do not diagnose, prescribe, calculate an unvalidated risk score, and do not recommend treatment. Cite source dates and label all missing inputs. The body composition subagent receives serial DEXA or equivalent source reports, weight history, lean mass trend, protein and resistance training history if documented, medication context, and the patient's goals. Its brief separates measured change from inferred cause. A change in lean mass is not automatically a conclusion about training adherence, endocrine disease, or medication effect. It identifies the question, source evidence, uncertainty, and what the physician should clarify. The orthobiologic readiness subagent receives the actual musculoskeletal history, functional limitation, prior conservative care, imaging reports, contraindication relevant data, and practice policy. Its role is not to declare a patient suitable for a procedure. It prepares a structured readiness brief, documented indication, missing diagnostic information, red flags, alternatives already tried, evidence limitations, and questions for the physician. It must explicitly flag where a procedure-specific claim lacks source support. The cognitive longevity subagent receives only approved data, cognitive complaint history, sleep information, mood screening if available, medication list, vascular risk context, and previously documented assessments. It does not infer neurodegenerative disease from a complaint and does not generate a diagnosis. It organizes potentially modifiable contributors, missing history, safety red flags that require immediate human attention, and the source dates behind each item. Each subagent runs in a clean context. Intermediate searches, false starts, and tool errors stay inside that subagent's workspace. The structured return must include scope received, evidence table with source, and timestamp, observations, contradictions or missing data, stated uncertainty, prohibited conclusions avoided, and all required questions for physician review. A subagent that cannot retrieve a source does not fill the missing blank from general knowledge. It always returns unavailable with the specific reason. It does not collapse 4 outputs into a single score. It verifies source links and detects all cross-domain conflicts. For example, if the body composition brief calls a medication active, while the cardiometabolic brief shows it as discontinued, the synthesis should display a discrepancy. The orchestrator then creates a staged physician review packet. Page 1 is an executive summary of cross-domain patterns with all unresolved questions. The following pages contain the 4 original briefs in full. The summary has direct references to each brief and provenance back to source. This is the critical design choice. No synthesis is allowed to erase the underlying work. At the pre-visit review, the physician reads the synthesis and drills into the source-supported briefs. The physician may determine that a purported cardiometabolic pattern is actually a non-fasting lab, that a body composition concern needs a different measurement interval, or that knee symptoms require a conventional diagnostic pathway prior to any regenerative medicine conversation. Those corrections belong in the clinician's judgment and, where appropriate, in ordinary documentation. This clinical commitment boundary is explicit. The agents can retrieve, organize, compare, and draft questions. They cannot make a final diagnosis, order testing, start a therapy, schedule a procedure, communicate recommendations to the patient, or write directly back into the chart. The physician uses the packet to work deliberately. It is not a plan of care. This mirrors a well-run tumor board or multidisciplinary team where multiple clinical domains prepare evidence. The chair sees the whole case and listens for disagreement. But the accountable clinician still examines the patient, validates the evidence, applies preferences and context, and owns the decision. Parallelism improves preparation. It never distributes clinical responsibility away. The mixture of clinicians model has real limits where decomposition can create false compartmentalization. Sarcopenia risk, knee pain, sleep disruption, cardiometabolic disease, and medication effects can interact. A subagent that sees only one slice may correctly describe its slice while missing the key interaction. The synthesis needs a physician who knows the patient, not a fifth agent. Parallel outputs also create consistency problems. Different agents may receive source packets, built at slightly different times and apply different language to uncertainty, or focus on a visually salient result while overlooking a temporal trend. Use one time-stamped source snapshot where possible, a shared schema, and clear conflict detection. Never treat agreement between similar models as independent clinical validation. Evidence retrieval has its own risk. If an agent consults an approved corpus, its sources must always be carefully curated and versioned. If it uses external retrieval, the system must label the source and its date, distinguish guideline from promotional material, and never create or invent a citation. A fluent citation-shaped sentence is not evidence. Every external claim still requires physician-level assessment of applicability, date, evidence quality, relevance, and clinical circumstances. Finally, sub-agent delegation adds operations. 4 focus briefs can be more useful than one giant chat only when task packets, access boundaries, and review are designed. Delegate only when domains are separable and the physician has time to review the work. A shorter response is not a substitute for inspecting the underlying source evidence. For every delegated clinical review, the rule is the physician sees the synthesis and the underlying briefs before any clinical conclusion is used. Each brief must name its source scope, timestamps, stated uncertainty, and missing information. If a source is unavailable, a patient identity is uncertain, a brief is incomplete, or the synthesis contains an unresolved conflict, the entire workflow stops at review. Subagents remain read-only and cannot commit actions. They cannot order, prescribe, schedule, send, or document into the EMR. The orchestrator stages a review packet. The physician decides what, if anything, belongs in the clinical record and plan. That is, the mixture of clinicians model done responsibly. This week, take one non-PHI de-identified example of a complex previsit review and divide it into 4 questions. Write each question so a consultant who has never met the patient could answer it. The domain, included evidence, excluded work, desired output fields, and prohibited decisions. Then look for the information that would have been lost if you had simply asked. One large chat to review the case, do not connect live clinical data, to a delegation system as your very first clinical experiment. First, validate the schema with fictional records. Make each subagent return a short evidence table, a missing data list, and 3 questions for physician review. If those fields are not useful to you, additional automation will not rescue the workflow. The hybrid physician is not someone who offloads judgment to many models. It is someone who can decompose complexity insist on source discipline, and bring several bounded analyses back into one accountable clinical encounter. This video is for educational purposes only and does not constitute medical advice or legal advice. Any implementation of AI agents in a clinical setting must be reviewed against your local HIPAA posture, state board requirements, malpractice carrier policy, and your own professional judgment. The physician always remains the accountable clinical decision maker.